Based on the different optical properties of different tissues, the Index of Plaque Attenuation is an innovative technique used to quantitatively evaluate plaque vulnerability. Vulnerable plaque refers to plaque that is prone to cause thrombosis and acute coronary events. Autopsy studies have shown that the main pathological features of vulnerable plaque are thin fibrous caps with large lipid necrotic cores, macrophage infiltration, and cholesterol crystal deposition. The light attenuation coefficients of these tissues are significantly higher than those of normal vascular tissues or stable plaques. Based on the strong attenuation optical characteristics of vulnerable plaque, the light attenuation coefficients of OCT cross-sectional images can be obtained. The light attenuation coefficient of each frame of the OCT cross-sectional image is converted to the IPA using Vivolight Medical's unique attenuation prediction model algorithm, which is used to quantitatively evaluate plaque stability. IPA technology was invented and completed in laboratory research by Professor Gijs van Soest at the Erasmus MC Medical Center in Rotterdam, the Netherlands, in 2016. In 2018, Vivolight Medical signed a scientific research cooperation agreement with Professor Gijs to complete the transformation of IPA technology into a new and important intravascular assessment tool. The evaluation of vulnerable plaques from two dimensions of histology and vascular structure is optimized to improve PCI treatment strategies. In 2016, the results of an in vitro study published in the International Journal of Cardiovascular Imaging showed a good correlation between IPA and manual lipid scoring, with a correlation coefficient R2 greater than 0.7. The conclusion of the study suggests that IPA is an efficient and reproducible automatic assessment technique for plaque stability that is not subject to operator subjective bias. Currently, common clinical assessment tools for vulnerable plaques include NIRS, coronary angiography, IWRS, and OCT, while all of them only evaluate the properties or spatial structural information of plaques from a single perspective. A research team has proposed the fusion of IWRS and NIRS technology for dual-mode assessment of vulnerable plaques. In 2016, the Nanodesigan team conducted an in vivo comparative validation of IPA and NIRS-IWRS, and the results showed that IPA technology can significantly differentiate thin-cap fibroatheroma from thick-cap fibrous atherosclerotic, while there was no statistically significant difference in the discrimination of the two by NIRS-IWRS. This study suggests that OCT-IPA can accurately identify TCFA and is superior to NIRS-IWRS. NIRS-IWRS combines acoustic optic technology in one catheter with lower resolution compared to OCT-IPA and higher consumables costs and a larger catheter outer diameter. However, IPA technology can be used with traditional OCT catheters without additional consumable costs, and IPA examination can be completed after one OCT pullback without increasing the procedure time. The yellow to blue gradient is used to present the magnitude of the attenuation coefficient value, where yellow represents a high attenuation coefficient value and blue represents a low attenuation coefficient value. The cross-sectional view can intuitively reflect the attenuation characteristics of each OCT cross-section, achieving qualitative analysis of plaque stability for each frame. The IPA value ranges from 0 to 1000 and can be used to quantitatively analyze the instability of plaques. The higher the IPA value, the higher the probability of vulnerable plaque. The lower the IPA value, the more stable the plaque or normal vascular tissue. The IPA long-axis indicator also uses a yellow to blue gradient to present the size of the IPA value. Yellow represents a high IPA value on the long axis, and blue represents a low IPA value. The IPA values of each frame cross-section in the entire OCT pullback sequence are identified by color, creating an IPA long-axis indicator. This indicator can provide a visual understanding of the distribution of vulnerable plaques and the maximum IPA value in the entire vessel segment. The First Medical Center of the Chinese PLA General Hospital and Vivolight Medical have cooperated to complete a series of studies on the accurate identification of plaque properties and the retrospective imaging review of plaque characteristics in patients with unstable angina using IPA technology. The latest research progress suggests that with an IPA threshold of 110, the sensitivity and specificity for diagnosing unstable plaques are 0.91 and 0.78, respectively. By comparing 30 autopsy biopsy coronary artery segments and 461 pathological slices. The results show that IPA can accurately identify the properties of plaques and provide risk stratification information through the level of IPA value. The accuracy of the IPA algorithm has been verified, providing important evidence for clinical application. In the retrospective study of the correlation between OCT images and IPA in patients with unstable angina, a total of 548 patients were enrolled, and the results showed a high degree of consistency between the identification of plaque components and vulnerability by IPA and that of clinical experts. Higher IPA values indicate a higher risk of vulnerable plaque, helping physicians to prepare for high-risk vulnerable plaques and prevent long-term risks. The IPA visualization tool can quickly locate the position of unstable plaques and effectively select the coverage area and landing point of the stent, avoiding complications caused by the stent being placed in an unstable plaque area. This tool can also prevent the misdiagnosis or misdiagnosis of vulnerable plaques due to the physician's insufficient OCT reading experience.